A very good morning, everybody. So, today's lecture is on growth and development, the basic concepts and theories of growth. So, at the end of the lecture, you must be able to know what is growth, what do you mean by growth and development, and what are the factors which affect the following, and the various methods of measuring growth, different growth theories, and how it is clinically applied in the use of functional appliances. So when we talk about orthodontics, remember the full name of the specialty is orthodontics and dentofacial orthopedics. That means two things: orthodontics, moving the teeth. Second is dentofacial orthopedics. That means we also deal with modulating or redirecting the growth of the jaws, orthopedics, bone growth, maxilla and mandible. Hence, we need to know in detail how to change the position of the tooth, the biology of tooth movement. Apart from that, we also need to know how the normal growth and development of maxilla, mandible, and the cranial base actually takes place and how our face grows. Because only when we know how the natural growth and development of these craniofacial structures takes place, only when we know what is normal, what are the correct timing, pattern, variability of these growth, then we'll be able to recognize what is abnormal, at what time, when, for which jaw we need to intervene and grow or redirect the jaw growth. Remember, in growing individuals, when we feel maxilla is not growing enough, we can actually make it grow. If we feel mandible is not growing enough or sometimes overgrowing, we can inhibit it from expressing that extra growth. So that's our role as a orthopedician, dentofacial orthopedics, using functional appliances or sometimes our orthopedic appliances. Whereas in non-growing individuals, if we want to redirect the bones, if there is some bony fault, that means the child has come to us at a very later age when no growth is remaining, then we do that by assisting the oral surgeons in undergoing orthognathic surgeries. Hence, when to plan for functional appliances or orthopedic appliances and when it is suitable for us to go for an orthognathic surgery is what has to be planned by an orthodontist. So we start with what do you mean by growth? It has got various definitions by various authors, but in short, it just means increase in size. Whereas development would mean a progress towards maturity. So if I make it simpler, growth is anatomical in nature, whereas development is more physiological and behavioral. Your differentiation, as we all know in our physiology, it means specialization of a particular cell. Like you see in this picture, you have a neuron or a red blood cell which will specialize in a particular function. So that's called differentiation of a cell. So there are various factors which will affect the physical growth of an individual. As we all know, it can be the genes, the hereditary. So if somebody's parents are tall, there are chances that the kids might also be tall. Same thing applies to the neurocranial functions and the structures as well. So if your father's, suppose, mandible is very big, there are chances that your mandible can also be big. The same applies to the dentition. If your parents have spaced dentition, there are chances that you might have a spaced dentition as well. So hereditary is the first factor which will affect the physical growth, followed by nutrition. If there is malnutrition at the growing age of the individual when active bone growth is actually taking place, then even if the genes are supporting good growth of the maxilla, that will not be able to happen because the cells need nutrition. Of course, it is said there is catch-up growth which should ideally take place once the nutrition comes back and it is actually restored, if it does not happen when the growth is over. Illness. Similarly, just like malnutrition, even illness can cause arrest in your growth, and ideally we expect a catch-up growth once the illness is eliminated. Similarly, we have race. It's not just the color. Individual race can have different standards of height or the growth of maxilla, growth of mandible. In few, maxilla being prominent, in few, mandible being prominent is normal. So it's a racial characteristic. Socioeconomic status, if you see, it will actually come down to your nutritional level. If your socioeconomic status is not good, nutrition can be hampered. If nutrition is hampered, your growth can be hampered. Same thing goes down to your family size and birth order. It is believed that if the size of the family is big, you might not be able to support the family socioeconomically, and hence the nutrition can be affected. Birth order also, the if you are a latter child, you might not be that much wanted, and your nutrition again might be impaired because of the same. Secular trends, it is said that with time in the population there are certain trends or changes that keep happening. So maybe there were taller people at some time, now there are shorter, the world is of short people. Okay, nothing personal, but there can be trends. So with time, certain things become in and certain become outdated. Then for climate and seasonal effects, of course, it's applicable for plants. It's not very applicable for us, but yes, it does relate in children, especially for adipose tissue. Psychological disturbances, yes, if you're psychologically disturbed, if there is stress, then your growth will be hindered because of less release of growth hormone. As far as exercise is concerned, yes, it does help in enhancing your motor skills and the muscle mass, but it is not directly related to having a more favorable growth. It is still controversial. So we come down to a concept of normality. So when we talk about normal, it does not mean ideal. Normal means something which is happening more commonly and which is forming a trend in a particular population. So we call it a normal, and remember, it cannot be just one thing or one value. It has to be a range. Just like you have your class 1 molar relationship, we cannot say it is the ideal molar relationship and others having class 2 and class 3 are not ideal. No, it is normal because it is found in the majority of the population and there is a range to it. Similarly, class 1 skeletal base, we can't say it is the ideal and those having class 2 and class 3 are abnormal. No, but it is found in majority of the population, so we consider it as normal, and we have given it a range that okay, between this to this degree we'll consider it as class 1 being normal, but it need not be the ideal. So we move on to concepts of growth. So the first thing is a pattern. Patterns actually refers to a set of proportional relationship at a given point of time, and it refers to the change in these proportional relationships over time. So if you look at this picture, this is a typical cephalocordon gradient of growth, and you see the first picture, which is 2 months fetal. The size of the head, the size the head is occupying in relation to the entire body is about 50%. With time, you see the size of the head is decreasing compared to the entire body. That means proportional relationship is what I'm talking about. Another thing, if you notice, is growth generally starts and ends first in the areas which are closer to the head, cephalo, and then it goes down to the caudal end. That means the tail end. In other words, it will be the cranium which grows first in a human being, followed by the maxilla, which starts growing first and its growth will end also fast. Next, it will be the mandible, then the upper limb, then the abdomen, and then the lower limbs. So when we are talking about growth modulation, we want to intervene, restrain, or try to grow a particular jaw. That time also we have to know this normal cephalocaudal gradient of growth. That means at a particular age, mandible being retrognathic can be considered normal because its age of growth has not come, and maybe the maxilla will be growing first, followed by the mandible. So we have to take into account this growth pattern and variability and accordingly time our treatment. So differential growth, also the different body tissues will be growing at different times with different rates. So this is broadly the types of tissues which are present. The general is including a maxillary and mandibular, which grows in the form of a S shape. If you look at the neural starting from here, you will see that most of the brain growth should take place by about 6 years. After that, your brain will more or less remain constant. If you look at the lymphoid tissue over here, most of the lymphoid tissue in the form of your tonsils and adenoids would be at its peaks. That means 200% of your adult size in its childhood. After that, the lymphoid tissue regresses with time by itself. Your genital tissue will be active with the sex hormone release, which will be about puberty. So we move on to the rhythm of growth. So this person, Houghton, he says that there are different waves of growth which happen, and he says there are 3 waves. That means sudden growth wave, increase in growth will happen at 3 point of times. First, he says within first 6 years is the maximum growth wave that will be noticed, followed by at the age of 10 to 12 years, followed by till you attain about 16 years. Of course, the growth in girls starts first and ceases first, followed by the boys generally. The most important growth spurts that we consider in orthodontics before planning our treatment are the following. Growth spurt means a sudden acceleration of growth which is coupled by a hormonal secretion. So one growth spurt or sudden increase in the growth happens just before birth. We are not going to alter that because it's not in our hands. So we'll be concerned about the growth spurt happening 1 year after birth, a mixed dentition growth spurt and a prepubertal growth spurt. Please note the timings between males and females. Each growth spurt is generally expected to happen first in females, followed by the males. So why we want to know this is, again, to time our treatment, especially if we want to grow the bones or redirect the bones. So we have to know which is the time where maximum growth is expected. That is the time where we'll give our functional appliance or orthopedic appliance. Or if for that matter the growth is over and the patient has come late to us, then we will make sure that no growth at all is left and all these growth spurts have gone completely. Then only we will subject a patient to a orthognathic surgery. So that's how your growth spurts look like. So we have removed the growth spurt which happens before birth because we cannot really utilize it. So we start with the growth spurt which is happening 1 year after birth, then the mixed dentition growth spurt, and this is the growth spurt that we'll be utilizing, which is our prepubertal growth spurt just before attaining the puberty, where maximum growth is expressed in the maxilla and mandible, the areas we are dealing with. So if you look at these, there is a dotted line which is representing for females and a continuous one which represents the males. So it is the females who lead always. And then there is an era where there will be no growth left and you can plan orthognathic surgeries with surgeons, of course. And this is the time we'll plan our functional appliances to grow the jaw bones. So there are various methods of gathering growth data. Longitudinal studies, that means studies which will be carried, so you catch hold of one person and you study that person over a long period of time. So long-term study, longitudinal. Cross-section is where you take a cross-section of different people at different time, cross-sectional study. So you're not holding on one person and for a long period of time. Different sample over different periods. Semi-longitudinal will be a combination of the above two. Then there can be various methods of studying growth, measurement approach and experimental approach. Measurement means you just measure. Maybe you can take skulls. Using skulls, you have craniometry where you can measure the skull parts, anthropometry where you can measure any part of the body, cephalometric radiology where the lateral cephalograms are the most commonly x-rays that we are subjecting our patients to. So you can take serial lateral cephalograms maybe after every 1 year and see how your maxilla and mandible are growing. What is the trend? Is it growing downward, forward? Is the rate of growth correct? Is it matching with the correct timing and the pubertal growth spurt? And depending on that, you find out whether there is a need to intervene and give a myofunctional appliance. Experimental approach will have the following 3. So vital staining means it was found that there are certain dyes which when injected get deposited in the bone and they help you find out the growth, direction, duration and the amount of growth the bone is projecting. So there are various dyes used. You have alizarin, tripoint blue, lead acetate and tetracycline. Similarly, you can use implants which can be made of biocompatible or bio-inert materials, like you have titanium and tantalum metal pins which can be inserted into the bones, and with time the surrounding bone structure will be growing. However, the position of that implant will not change. So you will be able to study how that particular growth of the bone is actually happening in which direction, seeing the relative position of that implant which will not change. Same way, your radioisotopes can also be used, which can be technetium, calcium, or potassium. Now we move on to the various theories of growth. That means these are the various postulates which have been given out by various authors telling how growth is actually taking place. Remember, this is a very, very important question. Any of the growth theories can be asked. So the genetic theory, this guy Brody, he says that entire growth is actually in hand with the genes. It's the gene which form the blueprint and nothing can be changed. Then you had the Sutural Dominance theory, where it says sutures, that means the point of attachments of various bones. There is deposition happening at the sutures, which leads to the adjacent bones being pushed in a particular direction, because the entire face is thought to be growing in a downward and forward direction. So it's the sutural, the local apposition and resorption taking place at the sutures, which leads to this entire shift and translation of the face with time, leading to growth of the entire face. However, there are various points which were against this theory, like when the sutures were removed and put outside, it was found that they do not have any innate growth potential. They could not grow by themselves. It was only the surrounding bones which made it look as if they had a growth potential, because they were moving apart. And also in patients who have a cleft palate means a gap, a cleft in the palate. That means the union of the bone is not there. Despite of that, normal growth, not completely normal, but yes, some amount of growth was still happening. That means in the absence of suture also. That means there are other factors which are leading to growth and development, not just the suture. So you cannot say a sutural dominance theory is true. Hence, various other theories were also put forward. We had the cartilaginous theory by James Scott, who said that it is the cartilage which is the prime source of all the growth. That is why it is in the earlier stages that an individual will be growing, and once the cartilage is replaced by bone with time, no growth will remain. And he actually showed that if the nasal septal cartilage is removed, those individuals, the mid-face development will not happen. However, there are points against, like your condyle. Your condyle is covered with a condylar cartilage, and it was noticed that those children who had a condylar fracture, which is very common due to a fall in kids, still the growth of the mandible happened in 80% of the children, despite of that cartilage missing. Then we move on to a very, very important growth theory. That's your functional matrix theory. Remember, it is extremely important and the most followed growth theory till date. You have to know this definition exactly, so I'll read it for you. The origin, form, position, growth, and maintenance of all skeletal tissue is always a secondary, compensatory, and necessary responses to prior events that occur in specifically related non-skeletal tissues, organs, or functioning spaces. That means it is the non-skeletal tissues, organs, and functional spaces which grow, because of which the skeletal tissue will have to adapt. So, Melvin Moss is giving importance to all non-skeletal tissues, organs, and functioning spaces for the growth of your bony or skeletal tissues. I'm sure you must have heard of people, in your prosthodontics also, people who do not have teeth, edentulous patients in older age, the alveolar bone will also not stay there. So it actually goes in line with your functional matrix theory. It's the teeth, which is a non-skeletal tissue, which makes the surrounding alveolar bone grow in response to its coming when it comes in the oral cavity. And once in old age the teeth are shed, the alveolar bone, the skeletal tissue, also goes back. So it's always the non-skeletal tissue which guide a relative development of its surrounding skeletal tissue. So this person has actually categorized it into different functional cranial components. So there are various functions which our cranium is supporting, which are the following: respiration, chewing, digestion, olfaction, vision, hearing, balance, speech, and neural integration. So in order to undergo all these functions, there are certain non-skeletal tissues and functioning spaces, and there are certain skeletal units or bony tissues which have been coupled together in a particular manner. So we categorize the functional cranial component into two parts: skeletal unit and the functional matrix. So skeletal unit will consist of your bone, cartilage, and tendinous tissue, whereas your functional matrix will be the non-skeletal tissue like your muscles, glands, nerves, vessels, and your teeth. So together, these components make a functional cranial component and a function is performed. So again, the skeletal unit and functional matrix can be subdivided into the following. We move on to the skeletal unit first. A skeletal unit, that means a bony component, has a macroskeletal. That means it has a macroskeletal. That means a big bone, which can be a mandible. A microskeletal would be each individual small parts of the mandibles. It can be the coronoid process, the condylar process, the ramus, the body, the alveolar process. So a number of microskeletal units make up one macroskeletal, and lots of macroskeletals, that means mandible, maxilla, they make up one skeletal unit. So when we move on to the functional matrix, there are two types of matrices. You have periosteal matrix and capsular matrix. So your periosteal matrix would be, if you look at this picture, surrounding any skeletal unit, that means condyle, you have number of muscles, blood vessels, and nerves. So the non-skeletal part immediately adjacent to a skeletal unit will be called a periosteal matrix. So if there are any changes in the need of the surrounding non-skeletal units, like if you use this muscle, there is increased blood supply. So these changes will lead to local deposition and resorption in this skeletal unit, and hence change in shape and form of this microskeletal, which will in turn change the shape and form of the macroskeletal, that is the mandible. That means it is the changes in the periosteal matrix which leads to a change in shape and form or transformation of your skeletal unit. Then we move on to the capsular matrix. So if you look at the face as such, there are broadly four capsules which are present. You have your neurocranial capsule, and the one we are dealing with is the orofacial capsule. If you look at this orofacial capsule which is shown in the figure, it is consisting of the nasal cartilage, the teeth, the part of maxilla, mandible. So basically it is consisting of many periosteal matrices along with its skeletal unit. And these capsular matrices enlarge with time, and they grow in a downward and forward position. When they move in a downward and forward position, they drag the components within it, that means the periosteal matrices and the skeletal units along with it, and lead to a change in position. That means translation of maxilla and mandible with time in a downward and forward direction. In other words, what I'm trying to say is your periosteal matrix will act directly and actively upon the microskeletal units by deposition and resorption, and lead to an active growth and transformation of the size of the skeletal unit. Whereas your capsular matrix is the entire capsule which all together leads to a passive growth or translation of the size and shape of the skeletal units that it is carrying inside it. So in nutshell, it is both together, transformation along with translation, which leads to a growth. So the entire capsule, orofacial capsule, is being dragged down and forward along with local deposition and resorption changes taking place in maxilla, mandible and all the skeletal units. So both capsules, periosteal and capsular matrices, are acting together, and both together are leading to growth and development of your face. So if I look at this, if you look at each microskeletal of the mandible, which is a macroskeletal unit, like coronoid process, a muscle which is attached to it is temporalis muscle. That means periosteal matrix for this particular microskeletal unit. So if temporalis muscle acts, it will lead to the growth of coronoid process, change in shape and transformation of coronoid process. Masseter and medial pterygoid muscles, which are attached on mandibular angle and ramus, will lead to a change in shape and form of angle and ramus. Similarly, lateral pterygoid muscle, which is a periosteal matrix for condylar process, will lead to a change in shape and size of the condylar process. And all this together, these periosteal matrices with their subsequent microskeletals are all together in the orofacial capsule, which will expand as the functions of the tongue and perioral muscles are taking place, and the entire expansion will make sure that the mandible also grows down and forward with time, apart from the local changes happening in its shape and size. So it is the translation plus transformation leading to the growth of face. So clinically, how we use this functional matrix theory is when we want to modify growth in our peak growth period. Suppose we diagnose a patient having class 2 malocclusion, that means class 2 due to a retrognathic mandible, where the mandible is behind and I want to grow the mandible. So how do I grow the mandible? We have come to know that the condyle will grow if the required muscles which are attached at the microskeletal can be stretched. Then the shape and size of this particular condyle and subsequently the entire mandible and the macroskeletal will grow. So what will I do? I will give a myofunctional appliance which will stretch all these muscles, modulate the function and hence grow the jaw. And I will not just the periosteal matrix, I will also change the capsular matrix. That means I will give the functional appliance in a forward biting position. I will make the patient bite in a forward position and give the appliance to the patient in that position, forcing the patient to bite in a forward position. When I do that, I stretch the entire orofacial capsule. So I am causing a translation and also a transformation change, because when the mandible is forced to bite in a forward position, there is continuous stretching of all the muscles happening, which will with time grow the bone itself, and with time that forward position will become the normal position of the mandible. That means the patient will actually become class 1 and the entire face will grow. The mandible will grow downward and forward to support that new position. Then we move on to a multifactorial theory by Van Limburg, where he states there are various factors which affect the growth. Intrinsic genetic, of course the genes are there. Apart from that, he says there are local epigenetic factors. Epigenetic means factors apart from genes but within the body. Local means which will act locally, like adjacent soft tissue on their respective bones. General epigenetic factors, again factors apart from genes but within the body, which will have a general effect like hormones. So if there is any hormonal disbalance, that will affect the growth. Local environmental. Environmental means now we have come outside the body, we are in the environment, but the factors which will have a local effect only in a particular area, like a habit, like a thumb sucking habit will have an effect only on the oral cavity, or a muscle force. So the muscle, wherever the muscle is attached, only that part will be affected. General environmental means again we are outside the body, but a factor which will have a general effect on the entire body. So it will be things like nutrition. If malnutrition is there, again the growth and development of the entire body is being compromised, or for that matter lack of oxygen. Then we have expanding V principle, which states that most of our bones grow in the shape of a V. So if you look at this picture, this is for our mandible. This is initially, and it is progressing and enlarging on the other side. So the V, with time there is deposition on the inner side, and the V keeps expanding and expanding. So it actually claims that most of the facial bones have this V-shaped configuration, and we can predict the growth by predicting the next V. The counterpart principle, again by the same author, says that yes, bones are growing in the shape of V, and they also have a counterpart. That means they will grow in harmony since all the bones are attached to each other. So maxilla's counterpart is mandible. So it says if maxillary growth is impaired, the mandibular will also be impaired. Similarly, nasomaxillary complex is in counterpart with the anterior cranial fossa. So they are counterparts. So any growth in one will affect the growth of its counterpart. So we move on to the last, which is the servo-system theory, which talks about a cybernetic language. So it says that your primary cartilages are mostly affected by your inherent factors, and they cannot be affected by local factors. However, your secondary cartilages, which is actually your mandibular cartilages, are said to be secondary in nature. These cartilages are the ones which are affected by your local factors more. A local factor, this is occlusal prematurity or any imbalance. For example, if it develops, then such factors will only affect our secondary cartilages. However, your primary cartilages will not be affected by local factors. It will be only affected by general factors like your hormones. Of course, hormones can affect both primary and secondary cartilages. Now, this theory says that it is these cartilages, primary and secondary cartilages, which are altering and making a closed loop system. So one change is affecting the other, is bringing on the another, and there is this loop which is going on in feedback to one and another response, which is never ending. So one change brings about the other, which brings about the third. Okay, so suppose there is an occlusal prematurity which is sensed. This change, this discomfort is sensed by the CNS, and the CNS is being guarded. It gives a response to the proprioceptions, the periodontium and the TMJ, and it asks the periodontium and the TMJ to adapt to this occlusal prematurity, and a new position of the condyle has to be set. So the condyle will in turn grow and make that occlusal prematurity disappear and make it normal. So this is a local factor which is making the mandible grow to eliminate the occlusal prematurity. But this condylar cartilage can also be guarded by your hormones. Whereas if you want a change in maxilla, it will be by hormones, that the hormones guide the maxilla and the occlusion is changed with the maxillary growth, and your performance, which is your mastication or whichever function which will be guided by the occlusion, is being performed, which can also change the growth in condyle. That's how we are using our functional appliances, where we are changing the occlusion. We make the patient bite in a forward position. The signal is sent to the CNS, and the TMJ, the periodontium, and the mandibular condyle is advised to grow with our change in occlusion. So we are actually using this servo system theory also to grow the mandible. Remember, that's why we claim more of growing the mandible, not the maxilla, because maxilla is primarily made of primary cartilages and it is attached to that. Hence, it is difficult for us to modulate the growth of maxilla, and we deal with modulating the growth of mandible more predictably. So that's how it's a cybernetic language where the performance, there is an amplifier, actuator, controller. So it's just being compared to a cybernetic language where entire system forms a loop. So next we move on to the tasks which I assign to the entire batch. So this is the first task for you. Task 1, what does this picture denote and what is its importance in orthodontics? Remember, I expect you to answer this task 1 comprising of 2 questions and task 2 comprising of 3 questions in the Google Classroom, which will be activated one day after the lecture date is over. Okay, so I expect all of you to answer task 1 and task 2 for me. This will be the assignment. So your task 2 is, which plant is this? What is its peculiar feature? And what is its significance in orthodontics? So there are 2 tasks, task 1 with 2 questions, task 2 with 3 questions. I expect you to answer these 5 questions total once I activate the Google Classroom for this particular topic. I hope you understood the lecture. If there are any queries, please feel free to share your queries. Remember, I'll be highlighting more on the clinical applications again as I deal with the growth of maxilla and a mandible individually in the subsequent lectures. Thank you, everybody. Stay safe.